Panelists. That's co-sponsored by the League of Women Voters of Greater Cleveland and by the Siegel College Lifelong Learning at Case Western Reserve University and the Plain Dealer and Cleveland.com and Lakewood Library. Tonight, we're going to be talking about opioids and the post-opioid era. I want to tell you about our next forum, which is coming up on December the 4th. We're going to be talking about plastics and Lake Erie, and that's going to be at Rocky River Library. I don't know if you're aware, but the recycling market has been roiled by China's cutting down on their imports of our trash. And so as a result, local recyclers are struggling with lower prices and difficulty of where they can put things. So what happens is a lot of the plastics end up in Lake Erie, either as microparticles or in some fashion. So that'll be on December the 4th. Tonight, our moderator is Brie Zeltner, who has been with the Plain Dealer since 2007. After a year-long internship at the paper, she reports on health effects of poverty on children, families, and the greater Northeast Ohio community. In 2015, Brie and colleague Rachel Dissel co-reported Toxic Neglect, which was an in-depth series that examined the unsolved crisis of lead poisoning in Cleveland. Zeltner has written extensively on health issues that disproportionately affect Cleveland's poor and minority children, including infant mortality, asthma, and substandard housing. In 2015, she received the New York Academy of Medicine's inaugural Urban Journalism Award. Zeltner is a Cleveland native and resident and a graduate of Dartmouth College. Brie?
Hi, everybody. Can you hear me okay? All right. Thanks for coming. I know it's a rough night out there, and we really appreciate it. I know that there might be some people who are here who are dealing with chronic pain, so if you feel like you need to stand up and move around, you can't sit down any longer, don't worry about it. Just go ahead. So we have, I think the way that I'm going to do this is just talk a little bit about what I know about chronic pain in my reporting, and then I'll introduce the folks to my left here and let them tell you a little bit about themselves. And then I would like to have this be as interactive as possible, so do a lot of question and answer as well. So I started reporting on this issue of chronic pain this year. I think probably it's been about a year, almost exactly. It was a sort of a natural offshoot of from reporting on the opioid crisis, because in doing so, I had worked with colleagues on a series of articles and started hearing from quite a few patients who were telling me their stories about being in pain for years, being managed on these medications well, feeling like they were doing well and were able to cope and work and be relatively pain-free. And then, some event had happened. They had lost a doctor, the doctor had retired, maybe a doctor had moved, or a primary care doctor had just decided that he or she could no longer treat their pain. And these folks had been left with very little recourse. There's not much you can do when your doctor says that he or she won't treat you anymore. Many of them had gone through withdrawal from these very powerful opioid medications that they've been on with very little support. It was really shocking to me to hear. You would think, this first do no harm thing, that there would be doctors who would be ready and willing to help patients, even if they did have to get them off of these medications, at least would be there to help them wean in a responsible way. And what I was hearing was that that wasn't happening for a lot of folks. So I started to look into it more and put out what we call a call in the paper and just asked for people to get in touch with me with their stories. And I was pretty overwhelmed by the number of people who had similar stories to tell. So I started writing about it, started learning more about it. Larry is one of the patients that I met during this process. Had heard almost exactly a year ago from a large group of patients who were seeing a doctor in Beechwood that they very suddenly had no doctor and didn't really know why and were struggling with that. So that was one of the stories that came out of this was that particular situation. But there are also a bunch of others, just kind of generally what's happening out there for these patients with chronic pain. In general, they're called legacy patients, these patients who have been on medications for many years. A lot of the folks that I was hearing from were older. They were older than 60 in some cases, some in their 70s. I heard from a couple in their 80s. So that was also shocking to me, is that these patients were, some of them on Medicare, and having such a hard time and feeling so much pain and not feeling like they had anywhere to go to get help. So that's kind of my background. So as I mentioned, Larry Harbert of Sagamore Hills is one of the patients who I got in touch with. He's been dealing with chronic pain for decades, and until recently was, like many other people that I heard from, pretty well managed on some opioid medications. So last year, he and many of the other patients that I mentioned who were seeing a Beechwood doctor for their pain management were suddenly left without care. So to Larry's left is Dr. Adam Hedaya. He's the founder of Cleveland Pain Care, and he is an expert in managing both spinal pain and other pain conditions. And Dr. Hedaya, I know because when I was reporting this story on these patients in Beechwood, many of them were referred to Dr. Hedaya. So that's how I came to talk to him, and he will be happy to talk about his methods for treating pain. And then to his left, we have Dr. Ted Perrin. Dr. Parran is the Isabel and Carter Wing Professor and Chair in Medical Education at Case Western Reserve University School of Medicine. He's also co-medical director of St. Vincent Charity Medical Center's Addiction Medicine Center, which is called Rosary Hall. So I thought maybe they could each talk a little bit about their experience in this arena, and then we can, I will have some questions for them, and hopefully you will as well. So Larry, you want to start? Or
Sure.
you want to kick off to one of them?
I'd
Up to
rather
you.
have one of them start.
Okay.
I'd be,
Dr. Hedaya?
well, yeah,
Just-
I'd be happy to start.
All right.
Makes more sense to me
Yeah, sure.
to do it that way.
Okay.
Sure. Can everybody hear me okay? Or am I too close? Well, Brie, thank you for having me. I want to thank our panelists for being here, and thank you all for braving this weather and coming out and joining us. So I'll tell you a little bit about my background and my philosophy on managing acute and chronic pain conditions, and sort of how it unfolded for me. So I started out with a background in neurobiology and physiology in my undergraduate program out of the University of Maryland. I ended up going to medical school, and at the time I thought I was going to do something in the surgical world, something along the lines of neurosurgery. I quickly realized that lifestyle was probably not something for me. And I became very interested in the brain and human behavior and neurology. And so after completing medical school, I went and I did a residency in psychiatry. And so I'm board certified in psychiatry and neurology. I also got another certificate in something known as functional medicine. You may be familiar with the Cleveland Clinic's functional medicine program, or you may not, and perhaps we'll talk about that in the context of our time here today. However, after completing my residency and receiving my certification in psychiatry and neurology and practicing for a couple of years, I realized something was missing. And I was encountering some patients with fibromyalgia. And I was thinking about various different avenues that I could go with my training, and I had the opportunity to train in a field that I was unfamiliar with, and it was pain management. And at that time, and I don't know if it holds true today, but this was in 2008 or 2009, these pain management programs were wholly owned, operated, and driven by the Department of Anesthesia. And so pain management was an outgrowth of anesthesia. Well, I had an opportunity to go to New York City and Mount Sinai Hospital and train with a group of anesthesiologists for a year in managing acute and chronic pain. Over 400 surgeries were performed a day at this center. We treated everybody from famous movie stars to people off the street. And I got a tremendous amount of experience. at the conclusion of my fellowship, I had the opportunity to move to Ohio and build hospital-based pain programs in rural communities in Ohio. And my philosophy out of the gate was, I don't understand the reason for chronic opiates. It didn't jive with my training in neurobiology, physiology, brain chemistry, mood disorders, affective instability, behavioral health, and psychosocial medicine. But I completed this fellowship, and we were trained to use high levels of opiates. I had the opportunity to sit with very esteemed leaders in the field, such as Russell Portnoy. You may have heard of him. He actually retracted his statements in the Wall Street Journal and New York Times around chronic opioid use. This was in 2012, I believe. I sat in on his lectures, or one lecture. He was, I believe he was a professor at Beth Israel, chairman of the Department of Palliative Medicine at the time. He was tied in with the pharmaceutical industries and well published, and he trained numerous people throughout the country. Nevertheless, I sat in on his lectures, and I remember thinking, this philosophy just does not jive with me. This doesn't make any sense. They're dosing dilaudid, a very strong, potent pain medication every 2 hours. The half-life is every 4 to 6 hours, meaning it lasts in the body for 4 to 6 hours. It peaks at 4 to 6 hours, but they're giving it every 2 hours. It goes against the grain in my mind. And yet that's what was being advocated. And so when I decided to embark on my career and build these hospital programs, my philosophy was going to be to reduce, eliminate, and move my patients away from chronic opiate use, utilizing everything and all of the tools that I had at my disposal, everything from interventional pain management to behavioral health to physical medicine to interaction with other physicians to Eastern medicine to functional medicine, anything I could do. And so I embarked. And the path was such that the primary care physicians would generally have started patients on opiates. They would escalate the opiates because that's what happens when you take opiates. You develop tolerance generally, you develop physiological dependence, and the pain relieving properties tend to dissipate over time as you become more tolerant and you require higher and higher dosages. And so the family doctors eventually would find themselves in a precarious position where the patients were requiring higher and higher dosages, and they would make the referral to a pain management physician like myself. So I would take hold of my patients, and this was back in 2009, and I would say, okay, we're going to work to reduce your opiate load. We're going to reduce the amount of medication you're on. And I'm happy to take you on as a patient, but the amount of medication you're utilizing is, I'm not comfortable with it. If you're willing to go down this path with me, I'm willing to fight alongside you. And we did this for a number of years, and we began weaning patients off of their opiates. And we built a very, very strong practice in the communities that we served. Now keep in mind, this is in 2009, well before the opiate epidemic was publicized, okay? So you could say I was progressive, you could say I was ahead of the curve, you could say my philosophy was against the grain, you could say I'm crazy, I don't know what I was doing. You could say whatever you want. I mean, everybody's philosophy could be different in this room. This is my philosophy, and I say that with complete humility because we don't know what we don't know. But it's based on my experience in education, having treated about 50,000 to actually having probably 50,000 to 100,000 patient contacts over 10 years or so. 50,000 to 100,000 patient contacts. Hearing story after story, listening to patients. Some of the stories are different, some of them are the same, some of the patterns are the same, some of them are nuanced and slightly different. I listen to everybody and I don't judge. Nevertheless, that's what we did. And about 3 or 4 years ago, I decided I really don't believe in chronic opiate use for chronic non-cancer, non-malignant pain anymore. And so I said, I just don't think, generally speaking, it has a place at this moment in human history and this time in this country. And I looked at some of the statistics, and I saw, well, 80% of the world's opiates are consumed in the United States. We have 5% of the world's population. 95% of this country, of this world, reserve the use of chronic opiates for perioperative pain control, meaning preoperative, postoperative pain care, terminal care, end-of-life care. 95% of the world. Yet we have 5% of the world population, and we consume 80% of the world's opiates. If you lump in Canada and Western Europe, you're at about 90 or 95%, depending on the statistics. Is it because we're the wealthiest nation? We're the most humanitarian nation? We have the best technology, the best resources? Or are there other things in the fold here? Is there capitalism involved? Is there big business? Are the pharmaceuticals partially to blame? Is it indiscriminate practice by some of my colleagues? What is the reason? I couldn't tell you. So, but what I could tell you is what I've read in the literature. And what I've read in the literature around chronic pain has led me to the following philosophy, position, and sort of lens and approach to pain management, which is that more likely than not, in many cases, chronic pain is rooted in cognitive, behavioral, psychosocial medicine with anatomic, musculoskeletal inputs. And what that means is that you can have an injury, you can have a spinal condition, you can have damage or trauma to the knee, you can have a post-surgical pain syndrome, you can have nerve damage. However, the need for opiates and chronic pain in particular in the brain almost exactly mirrors chronic depression. You get what we call a hypofunctional cortex, or the thinking brain, the thing that makes us rational and allows us to process information appropriately. And you get a hypofunctional emotional or limbic brain, meaning, or hyperfunctional, meaning hyperactive emotional or limbic brain. And a disconnect seems to emerge between these two processing centers. In fact, chronic depression may premeditate or be a risk factor for the development of chronic pain in many cases. And so what I realized is that by adding an opiate, I am probably fueling that fire. I'm not reinforcing the neural pathways in the brain to help somebody deal with the wind-up that develops around chronic pain conditions, or the emotions around chronic pain conditions, or the perceptions around chronic pain conditions. What I'm doing by providing a chronic opiate is I'm impairing a person's ability to self-regulate their own painful stimuli within their body. And so that's how I've come to see chronic pain for sort of generally. Now, I say that with complete humility because we don't know what we don't know. But I have sort of found that experience to be true sort of anecdotally in my practice. And so, you know, I think it's unfortunate, however, because we are in the midst of these sort of this opiate epidemic, and as Brie has said, these legacy patients. And I feel a bit disheartened by it because, you know, 4 or 5 years ago, I felt a moral, ethical responsibility to take hold of these patients and work with them and wean them from their medications. But that time is well beyond, we have passed those days. The medical literature, from what I can tell, in the medical community, and the will of this world has shifted so much that I think that the onus and the responsibility now falls more on the addiction medicine community. Not that these people are addicted in the sense that they're displaying aberrant behavior with regard to pain medication, but they are physiologically dependent. They're tolerant on these medications. Their lifestyle is predicated on the use of these medications. Their families rely on them. Their whole social system is built on their medications. And the medical community and the pain management community, from what I can tell, has known about this for some time, longer than perhaps even it's been articulated. And for whatever reason, it was controversial or they didn't act on it, and now it's sort of the prevailing philosophy. I'm happy to take questions. I hope I articulated that clearly. I'm not sure that I did, but if there are any specific questions, I'm happy to break it down. I'm happy to talk in a more scientific way as well.
That was great. Thank you.
Okay.
Yeah. Are you good now, or do you want Dr. Perrin? to go first?
No, I would like to just address a couple of Dr. Hedaya's points.
Well, how about we just have you introduce yourself and tell a little bit about yourself, and then we can have some
Okay.
more discussion.
Well, yeah,
Okay.
okay, that would make sense.
All right.
All right, can everybody hear me? All right, my name's Larry Harbert. I was a chronic pain patient for 12 years. I have multiple orthopedic injuries, surgeries. I've had over 70 surgeries. My right knee and pretty much my whole right side of my body is held together with plates, pins, screws. Underwent a 2.5-year series of surgeries called the Ilizarov Procedure using a Taylor spatial frame. It's kind of cool. NASA engineer designed it, moves bones, makes new bone grow. And that was due to a condition called osteomyelitis, which is a bone infection, recurring bone infection. I had it for 30 years. And finally found a doctor who said he could fix it, and he was right. Took 2.5 years, but he fixed it. Now, that was not what started me on pain management. All those injuries, everything, I just dealt with it. Aspirin, ibuprofen, whatever. And back in late 2005 or early 2006, I hurt my back doing something very simple, bending over to pick up a split piece of firewood. Something snapped, I hit the ground, and I left the house on a stretcher when an ambulance came to get me. And then I was on pain medication for 12 years for that. And the doctor I was seeing the practice was just suddenly shut down. I got no help from anybody, no support, through withdrawals after 12 years on MS-Contin and oxycodone. That was kind of rough. I think the problem when things like that happen, nobody that has been a compliant patient, followed all the rules, we had random urine screenings, random pill counts, nobody should be forced to go through withdrawals for that. If they want to take you off the medication, that's fine. There is an established standard of care. There is a procedure for that. You slowly taper somebody. You don't just stop. But unfortunately, that's happening to all kinds of people all across the country. And like Brie said, that's what they're now using the term legacy patients, because a lot of these people have been on these medications for decades. And the way it's being handled, I feel, is very wrong. These patients are not addicts. They are physically dependent, physiologically dependent, however you would prefer to word it, because any medication like that, if you stop taking it, you will become physically sick. You have to take it constantly. Something else I wanted to address here. Not everybody constantly escalates their dose of medication. A lot of people do. My opinion on that, that's one of two reasons. Either whatever their pain is caused by, be it disease, injury, something is either getting worse, or person has addiction, substance abuse issues. Because just as an example, in my case, I stayed on basically the same dose after it was adjusted the first 6 months or so. I stayed on the same dose for 12 years with the exception of that 2.5-year period of the Ilizarov Taylor spatial frame surgeries. Yes, it was higher dose because that was some rather intense bone pain for that period of time. As soon as that was done, right back down to the same dose. So every patient is different. And my opinion and what I know a lot of others' opinions are, there are people who they will get no relief from anything other than an opioid pain medication. That's not everybody, though. And like there are tons of alternative treatments, and no, you're not going to go from taking morphine, oxycodone, OxyContin, Dilaudid, whatever, to just using alternative treatments and feel fine. It doesn't work that way. But you can try alternative treatments, and you have to try. You can't just try one, stop, try another one, stop, try another one, stop. You have to do a series of things together. There's a whole process, a lot of things you have to do together. Try it. It can work. It doesn't work for everybody, and there are some people who will end up needing pain medication. Would you agree with that?
So I agree with much of what you said, Larry.
Okay.
I think if just to be clear, I think you have to approach each patient as an individual and each person as an individual. And I think it's very difficult to generalize and to say that everybody escalates their dosages of medication. So if I said that, I misspoke. There are a subset of patients that may not escalate their dosages of opiate medications. My personal experience was that it was far and few between. I didn't see a lot of that over the period of time that I prescribed chronic opiates, high dosage opiates. Oftentimes, there were extenuating circumstances like other surgical events or other health illnesses that would necessitate a periodic escalation, and it became a negotiation to sort of pull back at that point in time and recalibrate and find a new baseline. And that was a process that was, predicated on a trusting relationship between, the doctor and the patient, and an understanding of sort of what was happening, and that worked for a period of time. I think one of the biggest challenges was that these medications were overly relied on and overly utilized. And so I think what you're seeing today is sort of the converse, or the reaction to that, which is that there was this sort of liberalization, and pain was touted as the fifth vital sign, and you couldn't leave the hospital without, with anything less than, I don't even know, like a 4 out of 10 VAS score. Otherwise, the hospital and their administrators got dinged.
Can you tell us what a
the
VAS
visual
is?
analog scale, which is the little smiley face and the frown, and
The 1 to 10
yeah,
pain
the 1
scale.
to 10. And so, you'd have the patient on, MS Contin and oxycodone for breakthrough pain, and they're coming in with a 10 out of 10, and they're smiling. My pain is 10 out of 10, or it's 8 out of 10, and it never changes. It's always 8 out of 10. Sometimes it's 7 out of 10. You need a refill on your medication? Yes, Well, and so that was kind of the type of interaction that I think was happening. I don't want to say uniformly, but more often than not across the board. And so, and I think part of that was driven by patients' fear. Well, if I say my pain is 3 out of 10, is my medication going to be reduced? I can only speculate. Who knows? Nobody knows what was driving this behavior. But it was inherently flawed and problematic because a lot of these legacy patients, at least in my interaction, my practice, would fail a urine screen for whatever reason. Mm-hmm. They would come in for a random pill count, and they would be off on their pills. Mm-hmm. One of my first patients that I ever saw was an 80-year-old woman who was doctor shopping and getting Schedule II opiates around the state. And the DEA was in my office. And you would never have guessed, because she came in my office in a walker with spinal stenosis and all kinds of musculoskeletal issues and orthopedic issues. And so that is inherently problematic.
Of course.
And so I think that one of the things that I've sort of advocated for whenever I engage in sort of any kind of national dialogue, or I get up off my soapbox, so to speak, is I think that if you are going to consider using opiates for anything less than post-surgical or perioperative pain or chronic terminal end-of-life pain, cancer-related pain, or palliative care, palliation, I think the onus is on the medical profession to get some sort of baseline neurocognitive behavioral assessment to make sure that you are addressed, not a screening questionnaire like the opiate risk assessment tool that we have, which is a self-reported screening questionnaire, but some sort of psychiatric assessment, addiction assessment done by a real person who's experienced in this world. Because what is being missed in the medical community and in pain management physicians and across the board is the psychological, the social, and environmental inputs and the cognitive inputs that affect the way somebody perceives something that is noxious or painful in their body, that is maybe a locus of inflammation or pain or a structural problem anatomically that's affecting their physical being. And I think in the absence of that, more often than not, in my experience, you will be doing harm to people and their families.
That's actually a pretty good segue for Dr. Perrin to introduce himself and maybe talk a little bit about where addiction enters into this equation, what the differences are between dependence and addiction, as we've been talking about.
Sure. So I'm Ted Perrin. I'm an internal medicine doc, primary care internal medicine doc, and I'm also trained in the treatment of drug and alcohol addiction. Have been doing both since the early 1980s. And it's interesting. I was a history major before I went to medical school, and between 1990 and 1992, before then, no doctors ever gave opiates for chronic pain ever in America. So in the 1970s and 80s, if a person had surgery pain, we gave opiates. If a person had end-of-life metastatic cancer pain, we gave opiates. And everything in between was not treated with opiates. We weren't exactly told why not. We were just told that something terrible was going to happen to us and to our patients. So we just said, okay, and we didn't do it. And then the 1990s came, and some doctors who were very skilled in end-of-life care, palliative pain, had the hypothesis, it was a thought, that perhaps since opiates were quite helpful in the end of life with people with a lot of pain, maybe they were pretty safe in people with chronic pain too. And so without much data, there was huge change in prescribing. Throughout all this time, I was running drug and alcohol detox units and doing primary care, internal medicine, and also I was a consultant to pain management programs. And what we saw is what everybody knows, is that as the prescribing increased in the 1990s, all of a sudden our drug and alcohol treatment programs, Rosary Hall starting in 1994, as the cocaine epidemic started to ease, the prescription opiate epidemic began. And we switched between 1990 and 1995, in that 5-year period of time, at Rosary Hall, right here at St. Vincent Charity Hospital, taking care of the detox needs of Cuyahoga County. We found that we went from, on average, 5 patients a month admitted with addiction to opiates to 5 patients a day being admitted with addiction to opiates. So something happened with this increase in prescribing that activated what we call addictive disease. Now, this does not relate to Larry. because Larry doesn't have addictive disease. He has a series of very unfortunate orthopedic issues that resulted in him being on long-term opiates for a long time for totally legitimate medical purposes. They helped him cope during some phases of his life. He developed physical dependence to the opiates, but not addictive disease. If you take 100 people in America and you give them all opiates, about 10 out of those 100 people will begin to develop addictive behavior. But if you take 100 people in America and give them all beer, about 10 of them will develop alcoholism. It's about 1 out of 10 Americans has an addiction-prone brain, a brain that can and will develop addiction if it's exposed to euphoria-producing drugs like beer or marijuana or opiates or cocaine or any other sort of addictive substance. So it's about 1 out of 10. Now, people with chronic pain have a higher chance of addiction than the general population. You say, well, why would that be? Well, people who have addictive disease tend to suffer a lot of trauma. When you look at people admitted to Metro, to the Level 1 Trauma Center at Metro, with gunshot wounds, stabbings, bad car wrecks, Harley-Davidson wrecks on, Dead Man's Curve, et cetera, 60 to 70% of people admitted to the trauma center at Metro have addiction as their number 1 disease, and a gunshot wound with opiates in their urine or cocaine in their urine is a predictable consequence. So people who suffer multiple traumas have a somewhat higher likelihood of having addiction. So the rate of addiction in a general population of people in America is 1 out of 10. The likelihood of addiction in a general population of people with chronic pain in America is about 1 out of 5, about 20 to 25%. And the likelihood of addiction in a group of people with chronic pain who need more and more and more opiates over time is about 6 out of 10. Because very often people with chronic pain who get on opiates, who escalate their doses of opiates over time, they truly believe that their pain is getting worse. But what really is often happening is that the addictive part of their brain, which has a bottomless appetite for opiates, is asking for more and more and more every day. Some of you may have seen that movie. It was a creepy movie, The Little Shop of Horrors or something like that, where there was this plant that used to suck blood out of this guy every day, and each day it wanted more blood. That's addiction. That plant was addiction. In fact, since we're in a library, I should talk a little bit more about books. J.R. Tolkien, who wrote the Lord of the Rings trilogy and The Hobbit, J.R. Tolkien had a period of time in his life when he had opioid addiction. And he talks about Gollum and about this ring which took over Gollum's life at the expense of every other meaningful relationship in Gollum's life. And J.R. Tolkien was using the ring as an analogy in some ways to addictive disease in his own life until he got sober. So when if a person has addictive disease and they develop a pain problem and they receive opioids, it often complicates their addictive disease, and they tend to get worse and worse and worse. Now, what we're left with as a society is a generation of people with addictive disease who otherwise would have developed marijuana problems or alcohol problems or maybe amphetamine or cocaine problems, who actually have opiate addiction. And they honestly have been dying right, left, and sideways from overdoses, accidental fatal overdoses, because people with addictive disease try to take their medicine as directed and then they lose control and binge on it. Just like a person with alcoholism tries to drink like a social drinker and then loses control and binges on it and gets in trouble. It's the same thing, 2 different substances, but the same thing in the brain. And so we have a group of people with addictive disease in Cuyahoga County and America where this generation has developed opioid addiction. Where the previous generation it was alcohol and cocaine, And the generation before that, it was alcohol and marijuana. But this generation, it's opioid addiction. So we have a bunch of people with that problem. We also have a bunch of people with chronic pain who have been put on relatively high doses of opioids. As Larry said, MS-Contin is slow-release morphine, along with oxycodone on top of it, sort of if needed for breakthrough pain. In the 1980s, slow-release morphine was only given to people with end-of-life cancer pain, period. They're the only people who got slow-release morphine in the 1980s. But in the 90s and early 2000s and middle 2000s, on up until relatively recently, slow-release morphine was commonly given to people with chronic pain. And they would develop physical dependence, not addiction, but physical dependence. And the brain that has physical dependence, if you imagine, remember, I never saw this show, but I've been told by my patients when I describe this, they say, well, you're talking about the Radical Makeover show. Apparently there was a show on TV where a person would like go to work in the morning, and as soon as they drove out of the driveway, a whole crew would show up at their house, and when they got home in the evening, there'd be like a hot tub in the middle of their kitchen with a radical makeover of their house. That's what opioids do to the brain, to everybody's brain. They have massive effects on the brain. I think alluded to earlier in terms of depression, anxiety, a sense of suffering. You would think opioids relieve suffering, but long term they can increase the sense of suffering. And so when a person has physical dependence like Larry had, it's not quote unquote just physical dependence that we talked about 10 years ago, 20 years ago, 30 years ago. It's major withdrawal with an intensification of the pain, anxiety, insomnia, and a sense that you are on the verge of dying. I mean, literally feeling like you're dying, like everything in your body hurts from top to bottom in a way that's never hurt before. That's what opioid withdrawal is. And it takes the brain months, potentially years, in order to recalibrate itself back to the place where it was before it tasted opioids. And so patients who have addiction need lots of treatment for their addiction and all kinds of support in their recovery, as well as chronic pain management to take care of their pain problems. Patients who don't have addiction and just have physical dependence need either a very gradual taper, 5% a month or 5% every 2 months, in order to not precipitate withdrawal, but let the brain gradually come back down to normal, which is a 2-year taper. Now imagine a 2-year taper when the doctor has cold feet. And the doctor's saying, oh man, you know, people are getting in trouble for prescribing these days. I did this prescribing before, but now I don't feel comfortable prescribing. So doctors are backing out because they're afraid. And it's leaving patients having rapid tapers and withdrawal, which makes their pain worse. Or patients going to a medical withdrawal, a center, a detox unit like we have at Rosary Hall, at St. Vincent Charity, and several other treatment programs in the community, many of which my group helps to manage, and be detoxified or medically withdrawn off of the opioids in about a week, while at the same time getting a pain management consultant to consult with them to start treatment for the chronic pain, as well as a recovery consultant to come in if the patient has addiction. So it's a very complicated situation right now, and many patients are finding themselves either gradually but too quickly taken off, or abruptly taken off like Larry when the doctor that he was seeing got in trouble. And when the doctor gets in trouble, the office is closed, the doctor has no license, and the patients are looking for a detox unit to try to help them go through withdrawal management.
Larry, if I could just interject and piggyback on one of your points, and this concept of the gradual taper for the sort of opiate-dependent patient. One of the biggest challenges is that 2-year taper never occurs in a vacuum.
Yep.
Real life exists. And you've alluded to this so eloquently, which is that chronic pain patients have a history, generally, chronic pain patients that are on chronic opiates many times have a history of trauma in their past. And so as you engage in that sort of tapering process, inevitably, other traumas occur over that period of time. Whether they're real or perceived, whether they're anatomical, physical, or psychological or emotional, people don't exist in a vacuum. And so that 2-year trauma, that 2-year taper is exquisitely challenging. And these legacy patients, if you are running a compliant opiate management program, will fail that program in that taper, more often than not. My experience tells me that. Because they know the mission is to wean away from these medications in time, and even if they have a willing practitioner, something happens. And they may not tell their doctor, they may communicate it to their doctor, but there are guidelines you must follow.
Sure.
And so it's a real problem. And so I think that even the best-hearted physicians and the most well-intentioned patients run into a problem with the dynamic as it's set up. And so I just wanted to add that because I think it's an important nuance and point, and it's sort of based on my experience. So thank you.
So one of the immediate questions that I have, having heard from everybody, and really thinking about what you were just talking about, Dr. Hedaya, is the need to have a compassionate and careful weaning of a lot of these patients. And you mentioned that 3 or 4 years ago you felt a moral or ethical obligation to do that weaning for patients, and I assume you're not doing it anymore, or you're not taking on patients who are currently on opioids and need management. And I guess my question is, when you have a patient like Larry, or like many of the other ones that I've heard from, who need that help, where do they go? And why are there not enough doctors who are willing to do this? I mean, it seems like a very basic kind of care for the person's health. I've talked to too many patients who have gone through withdrawal at home, and as Dr. Perrin mentioned, it's exquisitely painful, and it can feel like you're dying. I've had those patients tell me that they've gone to emergency rooms in the area and been turned away, that they're pretty much just left on their own, some of them in so much pain that they're only able to crawl around their homes. So when that's the case, I wonder, what is the solution? I know that part of the solution can be a careful detox in an addiction treatment center. I've heard from some patients who've gone to Laurelwood, they've gone to Rosary Hall, places like that, but a lot of them resent that because they do not feel that they are addicted to the medication. So where is the ethical obligation from doctors to take care of these patients, and where do they go?
Yeah, I think it's an excellent question, Brie, and I certainly, my position is not from a place of being insensitive or lacking compassion. I think it starts with education, at least in my practice. And I have a conversation somewhat similar to the conversation we're having now with any patient who comes into my practice about my philosophy. I generally will say, I'm happy to take you on and manage your pain. However, I do not prescribe opiate pain medication. That is something that I do not believe in philosophically for chronic pain at this moment in time. And I then sort of query them, and I say, well, what happened with your last physician? In the case of Larry, we know what happened to him. But if they're coming to me, oftentimes it is, my physician got shut down, he fled the country, or the DEA raided him, or he was something amiss occurred. And it's sometimes not clear, sometimes it is, sometimes we can find the information in the newspaper. But so I say, well, how much medication do you have available? Because you have a couple of different options. And option A would be, if you have adequate medication, you could gradually begin to wean off of this medication, and I can give you sort of a rather aggressive weaning schedule. I don't know if it will be successful. However, I recognize that your brain is not functioning 100% as a result of these substances that you have been taking for, in some cases, 1 to 2 decades. And however, once you have weaned off of these medications, there are some other medications that we can utilize that have opiate properties, that are used for pain, that are not Schedule II narcotics, that can help to rebalance the pain receptors in your brain. I don't know if that will be successful because of the length of time you've been on the medication, the dosing, the frequency, and your history. I'm willing to go down that path with you. However, in some cases, I will say it is my opinion that the better path would be to see somebody like Larry and undergo detoxification if you're willing, and you can handle sort of whatever the stigma is around that. And I will educate them. I will say, you are not a drug addict. You have been, in my humble opinion, things have been mismanaged for quite some time, and you are physiologically dependent, and these are the symptoms you can expect. And for me to take hold and manage your chronic pain, which I am good at, I believe. I'm not good at managing opiates anymore, and I don't do that, and that's not what I specialize in. But for me to take hold and go down this path with you and manage your chronic pain, this would have to happen first. And so I give options. Now, you're right. There are physicians in the community. I hear these stories all the time from my patients who will just reject them at the door or refuse to even see them. And so I think I understand where they're coming from because there's a medical legal implication, right? And I think there's a lot of distrust in this environment today, and people are running scared. From my perspective, I have always tried to be progressive and part of the solution, and so that's where I am with this on a personal level. I wish I didn't hear stories about sort of doctors sort of rejecting patients at the door. I find that a bit frustrating because I think one of the first maxims of being a physician is do no harm. And sometimes that's just about educating and saying, look, this is where we are today, and this is where you are today, and this is what could happen, and these are the medical treatment options, and these are the risks, and these are the benefits, and you know, my moral ethical obligation and responsibility is to provide information so that we can make the best decision together. Whatever that decision is, I would be here to help you and support you in that process to the best of my ability based on my boundaries and comfort and limitation as a physician. And so, even though I'm licensed to practice medicine and surgery in the state of Ohio, you're not going to come to me and ask me to do a colectomy, remove your colon, right? If I tell you that's not what I specialize in. Mm-hmm. So, and I think a lot of physicians, primary care physicians, are probably taking the same position, whereas, well, this is not what I'm going to do anymore. I'm not going to manage these pills. That's beyond my scope. I don't understand.
Right, and in your opinion is that, I understand you saying that that's not what I do. I'm not a pain management specialist. But when we have this situation where there aren't enough pain management specialists to go around, and you have patients like Larry who are calling 40 or 50 doctors and being turned away, I've heard the argument that primary care physicians are actually in the best position to manage people with chronic pain because they know them well, and because they know their history. And when patients are compliant, then they can do pretty well in that setting, and that maybe there should be more training for primary care physicians to be able to feel confident to handle patients with chronic pain.
That's a very interesting point, Brie, and I think there's some merit to that because oftentimes I'll speak with a primary care physician and they'll say, well, I have the patient on this medication. Would you support me in continuing this medication and working to gradually wean them? And they may have, like you said, a better working knowledge of this individual, their family, their circumstances than sort of a specialist. And I always say, you do what you feel is right. I would be supportive of that, as long as you're comfortable and you're following, your guidelines. Mm-hmm. And I would continue to treat the patient alongside you. Mm-hmm. And I do that, and we have those relationships. Those relationships do exist. That's not as common as it was several years ago. Right. And so I, from a personal standpoint, I'm a bit frustrated because, and Larry, feel free to please chime in. I sort. Well, I'm sorry.
Ted.
Oh, I'm sorry. Ted.
That's all right.
I apologize. Feel free to please chime in. But I feel, as somebody who has sort of been in the mix and the fold with my patients and sort of fighting, if you will, the good fight for the last decade, that and educating some of the family doctors over the years that I've had the opportunity to interact with and other physicians over the years, and continuing to do so, that some physicians chose, if you will, to take the easy path. And rather than and maybe it wasn't the easy path for them, maybe they had something else driving them, but rather than engaging in this dialogue several years ago with their patients, they just continued to do what they did. And you know, it took sort of the federal government and our president and all these other kind of factors to sort of get into the fold, and the CDC guidelines and all of these other things before people just sort of reacted and just slammed the door.
Mm-hmm.
Right.
And I think that, yeah, it is. And it's high, and people's lives are being destroyed. I mean, we see people in our office every day who are in crisis, absolute crisis. And so I don't have a clear answer for you, Brie, but I just wanted to expound on your comment. And but we don't shut our doors. Our doors are wide open, and we will do everything we can. If it's a referral for behavioral health, if it's working in other avenues to help manage the pain, if it's collaborating with primary care physician, whatever we can do. Mm-hmm. I mean, we really, truly want to be part of the solution, and that has always been the case.
Dr. Perrin, I have a question for you about addiction, and you touched on this a little bit, but I think it's a really interesting point. You mentioned that in the 90s, before you started to see the rise in people who were addicted to opioids, there were a lot of cocaine addiction issues in the area. And we had a conversation about this once before, because I think that there's a common belief right now that the rate of addiction has skyrocketed, that there are a lot more people who are addicted now than there were in the past. Yeah. And is that true?
It's a great question. It's certainly not true. If we can turn our memories back to 1990 to 1992, if you read the newspaper or watched the news in Northeast Ohio, you'd think that the world was coming to an end because of crack babies.
Yep.
Right? The future of Western civilization as we know it was going to come to an end because of the crack cocaine epidemic and crack babies, and oh my gosh, the sky is falling and our pants are on fire. And the reality is the cocaine epidemic was a disaster. It was an absolutely devastating addictive epidemic. And it affected between 10 and 15% of people in the community. The current opiate epidemic is an absolute disaster. I mean, if I went to all of the wakes of all of the patients that I've treated who've died from accidental fatal overdose on opiates, I almost wouldn't have enough time to practice medicine. So many people have died. It's an absolute disaster. But opiate addiction affects 10 to 15% of a population that uses opiates. And we've been in the middle of an alcohol epidemic ever since the end of World War II. I mean, before World War II, we had prohibition, and we had a society where better than 50% of adults didn't drink any beer, wine, or liquor ever. And we came back from World War II a male-drinking nation. And women born since 1950 drink at the same rate that their male counterparts do. So now we have a male and female drinking nation. And 10 to 15% of Americans, if they drink, develop alcoholism. It's the same 10 to 15% that if they snort cocaine wind up freebasing crack cocaine and selling their lives. And it's the same 10 to 15% which if they get started on opioids for a pain problem, or if they hear about chewing Vicodin and drinking beer at a fraternity party is cool, like in the late 90s and early 2000s on a lot of college campuses, if you have addictive disease, whichever one they start on, that's what will activate them. So we have the same rate of addiction in America that we've had since World War II. And that's 10 to 15% of people at some point in their lives will develop alcohol, marijuana, opiate, or amphetamine addiction. 10 to 15%. And the rest of Americans may at times be big partiers in a dangerous way, or they may be social users during major parts of their lives. They may be abstinent during parts of their lives, but they just don't have addictive disease.
Mm-hmm. I think that's an important point for me, at least, to emphasize, is that the rate of addiction hasn't changed. The drug of choice that's in play right now is so much more deadly than, say, cocaine was. So that's why we're seeing the horrible numbers of overdose deaths. One of the other things that I want to talk about a little is what people are using when they're dying. That's changed over the years, and I wonder if we could talk a little bit about whether that common narrative of the person who has back surgery and gets a prescription from a doctor for oxycodone or something else, and then starts escalating the dosage, and then goes out and starts taking heroin, whether that's still true predominantly, and if we could talk a little bit about things like fentanyl and the other drugs of that nature that have come on the scene recently.
Sure. So when the drugs that we were dealing with were primarily, OxyContin and MS-Contin and Dilaudid and Percocet and such, we saw some overdoses. We saw a huge surge in people with addiction and some increase in overdoses. When the heroin started coming to town in about 2005 here in Cleveland, 2003 to 2005, we started seeing an uptick, really for the first time since the last few years at the end of the Vietnam War. We saw an uptick in heroin. It was, quote unquote, just heroin. Just heroin, but it was just heroin. And we saw some increase, a marginal increase in overdoses at that point too. In about 2009 is the first time that in Northeast Ohio we first got fentanyl or carfentanil or sufentanil, some of the synthetic opiates that are 10 to 100 times more potent than heroin. Imported here into Northeast Ohio. And don't ask me why they came to Northeast Ohio, but they came to Northeast Ohio. They came here, they came to Newark, New Jersey. There was a suburb of New York City where they came to, and you saw this sudden spike in overdoses. And the reason is because if you have heroin, and it has a certain purity, and then you have fentanyl, and it's 100 times stronger than the heroin. You have to very carefully mix that fentanyl into the heroin, otherwise some of the bags of heroin won't have any fentanyl in it, and some of the bags of heroin will have a fair amount. And if a person gets one of the bags of heroin that has a fair amount of fentanyl in it, they will die. I mean, that's all there is to it. If you're used to taking heroin and you suddenly get a bag that's 30% fentanyl, or even 10% fentanyl, it will overshoot your tolerance. It will have been as if you took 10 times more than you normally take, and you'll just stop breathing. And so that's what we saw. It really started, the first inklings of it were 2009. It hit Northeast Ohio in a big way in the last half of 2010, and that's when we saw the rapid escalation of overdoses. So the overdoses that we would see on opiates in the 1980s in Cuyahoga County, you could count in a month on one or maybe two hands in a month in the 80s. In the mid-90s, when OxyContin 40 milligram or 80 milligram was out there, and people, were sort of experimenting with that and taking it and not being exactly sure what their tolerance was, we started seeing overdoses in the, 20 to 40 a month instead of one handful, 5. From 2010 until its peak in 2016, we lost like 860 residents in Cuyahoga County to accidental fatal overdose on opiates. From 5 to 860
Right.
in a month.
And in 2016, almost 60% of those unintentional overdoses were due to fentanyl
Yeah.
and its relatives, and
Yeah.
the only about 14% were due to prescription opioids, which is the lowest level that
Yeah.
it's been since 2009.
Can I say one thing about the OxyContin when it started?
Yeah.
And I can provide you a link to it too if you don't believe this one. 80% of the people that were abusing OxyContin never had a legitimate prescription for it.
That's for sure.
They weren't going to the doctor and getting OxyContin and becoming addicts and taking too many of them and overdosing on it.
That's absolutely true. There's a tremendous amount of diversion. So doctors were prescribing big amounts. Since there's a street value, if you're getting more than you... I mean, kids in junior high school never sell their lunch. They sell their leftovers. You sell your dessert in junior high school. People never sold what they needed, and people who were getting what they needed just took what they needed, like in Larry's case. But people who were getting substantially more than they needed, would share with friends, and then a friend would know a friend who'd know a dealer, and then before you knew it, you could pay half your rent in the month. And you didn't really deal with the dealer yourself. It just went to a friend who then went to another friend who then went to the street. And so the abuse of the prescription opiates, when we first started seeing people switching to heroin in 2004, 5, 6, 7, about 80% of people who went to heroin had started with prescription opiates. Now it's way less than 50%. The people who are going to heroin and fentanyl now are generally just starting off with heroin and fentanyl now, the majority of them, because there's been a decrease in the prescribing. The prescribing's down about 30% from its peak. But as we've said before, the peak of American prescribing with 5% of the population and 80% of the world's opiates prescribed is pretty high. The prescribing still needs to come down. But that doesn't mean that stable patients who are adherent and who are doing well should be cut off and left out in the cold. The reality is that any amateur pilot knows that if you don't know how to land, don't take off. But I spend all of my day, every day, teaching medical students, residents, and practicing physicians how to get people off of benzodiazepines and opioids, because they are two of the most commonly prescribed classes of medicines in America, both of which can produce physical dependence and therefore withdrawal and horrendous situations for patients. And easily 90% of people who prescribe benzodiazepines and opiates have very little idea about how to take people off them. And that's just the reality. I mean, it's not right, it's not just, it's a failing of the medical education system, but it is the truth. And so when you look at primary care docs and say, well, why don't you safely take the person off since you started them on it? They honestly don't know how, number one. When they try to taper, they tend to taper in huge chunks, which puts people into withdrawal, and then you have worse pain, and then you go and say, I can't taper, and then they say, oh my God, you can't taper, you must be an addict. Why don't you go find a detox unit somewhere? The majority of primary care docs don't even know how to refer a person to a medical withdrawal unit. And they don't know how to use the language of, with one patient with addiction, saying, we need to get you into a drug and alcohol treatment program starting with detox. And with another patient, perhaps like Larry, saying, I can't keep prescribing to you anymore, and I'm not going to be very capable of tapering you down. Let me refer you to a medical withdrawal unit. That when you go there, you might hear a lot about detox, but you're just there for medically managed withdrawal. It's the same program, it's the same facility. We're clearly capable of treating both kinds of patients. But the stigma of having to go to a detox unit and a drug and alcohol treatment unit is enough to put some patients off so much that they wind up staying at home and going through awful withdrawal. When in a 6 to 7 day medically managed withdrawal in a hospital, we could get them off, or a 3 or 6 week taper with buprenorphine as an outpatient, we could get them off. And it's a shame, but it is the reality. Mm-hmm. It's not right.
So I have kind of a follow-up question to that, and
May
this
I
is
add one thing, Brie?
yeah, quickly.
So, in addition to the stigma, I think there are economic challenges. There are family challenges. There are other responsibilities that make that very challenging for some patients.
Yep.
The other thing is, in terms of the medical community and their capacity and ability to engage in a gradual weaning process with a patient and their lack of training and sophistication in this arena. And this comes back to some sort of my original point, which is that unfortunately I feel that at this moment in time, a lot of this falls on the addiction specialist or the psychiatrist, because in order to engage in a weaning process with a patient who's sort of what we call chemically dependent on opiates, there are psychological, emotional, physical inputs that need to be taken into consideration in that journey. And part of what's required on the part of the physician is consistent limit setting, boundaries, negotiating, and accountability. And so that is an addictionologist who has that training. Mm-hmm. That is a psychiatrist who has that training. That is not a pain management physician.
Sure.
And so the pain management physician, while they may know how to wean somebody off their opiates, if the patient can't do it in 3 months, or fail their urine screen, or fail their in this process, or fail to follow through, more often than not, and Larry may be able to share some of his personal experiences or experience with friends, they will be dismissed from that practice. And so they're left on the street. And so this is part of my overall frustration, which is I felt that the time for this, at least in my practice, was several years ago. Mm-hmm. And now I feel like we need the addiction community, and I don't know if there's the will, and the psychiatric community to, rise to the occasion, because they're the ones with the skills. Your average pain management physician doesn't know how to do this. Mm-hmm. They're not trained to do this. In their 1-year fellowship, they may have had 2 weeks of psychiatric experience. They come from a world of anesthesia, and if you want to talk about, the model or lens with which we view pain management, well, it generally has been an outgrowth of anesthesia, which anesthesia exists in an acute care model, right? They as a function of their role, they generally alleviate pain, put people to sleep, and anesthetize them. And so from there, they became sort of these chronic pain managers. Well, chronic disease requires a very different model and a very different lens to get people well. And so the model, I think, has shifted or evolved, or maybe the pendulum has swung. I don't know. But I think that it's inherently problematic with our medical community right now. And I think that's why people are slamming the doors, because they don't know what to do. And they're overwhelmed by it. And they don't know how to take this on. And so it's fundamentally problematic. Maybe we should teach a course.
Yeah, there you go.
Yeah.
All right, I'll say a couple things to that. One, most people that I saw get kicked out of a pain management program, okay, they have bad pill counts. They don't have what they're supposed to have when they have a urine screen, or they have things they're not supposed to have when they have a urine screen. Yep. That's not a compliant patient. So, fine, kick them out. But why are patients who were compliant, had good pill counts, had good urine screens for a decade or more, also punished? They are getting punished.
Very, very common sentiment and argument.
And it goes to the point of this pendulum swing. I mean, we started out with the easy solution of prescribing a lot of pills to patients, and then we've swung to, it's much easier to just say you can't have them anymore at all than it is to actually manage the patient through. As you mentioned, it can be a 2-year process. There's the psychological parts of it, and so this one question that I have, and it might be a little bit of a politically charged question, but we're at a point now where prescribing levels are lower than they've been in a decade or more, and yet we're seeing the overdose deaths climb still in this state. They're dropping in some places, but they're still climbing here. And so I wonder if even if we were able to get everybody off of opioids and stop, just not prescribe them to anybody else, is that going to solve the problem? It doesn't seem to be having the impact that folks might have thought it would or would like to see it happen. And then you get this conflation of people who have pain with those who are dying of the overdoses and who have addiction. And one of the most unfortunate outgrowths that I've seen from this is folks who have chronic pain, who have gone through horrific situations like Larry has. And Larry, I'm not putting this on you, but many people that I've spoken to are openly antagonistic towards those with addiction. They want to separate themselves from people who have an addiction because they feel like that's not me, that's not their problem is affecting me. And I've been compliant, I've been taking my medications. Why should I have to suffer for what these people, and they use some awful names sometimes for people with addiction, are doing to themselves? So I wonder if what we're doing in terms of cutting off medications is having the effect that we'd like to see, and what the side effects of it are in terms of vilifying people who have addiction and then leaving a whole group of people who have legitimate chronic pain needs feeling like they're now stigmatized as well.
So let me just say something here. So unfortunately our societal experiment with chronic opiates for chronic pain was a bad idea. It was a bad idea to start with. It just was. It didn't have much science behind it. It has resulted in a tremendously devastating situation for many different groups of patients. We have a generation of people with addictive disease who have opiate addiction rather than the other addictions they would have had, which typically are less fatal. We have a group of people with chronic pain who have been iatrogenically caused by doctors to not only have chronic pain, but to also have chronic physical dependence to opioids, which in and of itself is not necessarily a bad thing. And there are some patients in that situation where perhaps like in Larry's case, if someone had just let him continue on the course that he was on, he would have done fine. And perhaps in his opinion, which is probably the best opinion to take, done better than the other alternatives that have happened in between. But there's also a lot of people with chronic pain who don't have addiction, where opioids have actually actively deteriorated their capacity to function. The majority of people with chronic non-malignant pain who were put on chronic opiates who didn't have addiction, the vast majority did not benefit from the opiates, and actually, when you look at them, had a deterioration in their biopsychosocial, spiritual, familial functioning. So we've got basically four groups. 3 of the 4 have been damaged by the prescribing of opiates for chronic pain. And one group, I suspect the group that Larry's in, which is a legitimate group that makes up, my guess is, probably about 20% of people with chronic non-malignant pain, is a group who actually functioned okay or maybe even better with opiates. But the majority didn't. And it's almost impossible to tell before you put people on opiates which group they're going to fall in. You can tell who has addiction. That's typically not too tough. But of the other 80%, it's hard to know which 20% are going to do better and which 60% in one way or another over time are going to do worse. And so I think what you're asking for, which is we as a medical community did the wrong thing. It did benefit 20% of people, and we can't tell which 20% in the future that might benefit. But it didn't benefit and actually hurt 80% who went down that road. So since we can't tell which 20% would do better, and since clearly a majority have done worse with chronic opiates and chronic pain. And there isn't a good theoretical research basis for doing it in the future. I think we're going to see less and less and less long-term opiates and chronic pain in America. I think that's just the reality. And the generations of people with addiction or with physical dependence who are now being hurt by being taken off of their meds, that generation of both those groups, it's a shame.
I guess the other thing that I'm asking or trying to get at is, with drugs like fentanyl and carfentanil and other really powerful opiates in the community, are we really going to see a significant drop in the number of overdose deaths by cutting prescription medications?
No.
So I don't think, at least from my standpoint, the reason, and Ted, feel free to echo this if you agree, I don't think the reason we're not at least at this table, at least for speaking for myself, I don't think the reason we're not prescribing opiates is because of, at least for me, fear of overdose.
But you have to acknowledge that that's the reason in a lot of guidelines, that's the reason in a lot of political speeches, this is what we're doing in order to address the overdose crisis. And my question is that actually doing that?
No, I think from, and when I meet with patients, I don't even talk about that, the politics of it. I talk about, what I consider to be best practice for managing chronic pain. I don't even know how to address that. I mean, that's a bigger issue than I can even comment on.
Okay,
Yeah.
how about this though? There, however you look at it, there is a percentage of people who have chronic pain who do well on opioid pain medication, and those people who have been compliant patients for however long do not deserve to be just taken off those medications if they were doing well on them. Now, I agree. You have people that abuse the medication. You have people that doctor shop, like your example earlier. Well, not anymore. You can't, but
Yeah.
but there are people that benefit from it. No, it's not the majority. I'll agree with you on that. But there are people who benefit, and there are people who are being very seriously hurt right now because they cannot get pain medication. There are people committing suicide because they are in so much pain, because they were cut off, rapid tapered, or, just cut off, no tapered.
So you're right. There are people who are, well, first of all, it's not like no doctors prescribe long-term opiates anymore. But the doctors who do prescribe long-term opiates are not real eager to take patients, new patients, who are on long-term opiates into their practices. So I know a lot of doctors who continue to prescribe long-term opiates to very stable patients who've been on them for a long time and have no plan to make any changes. But those doctors are generally unwilling to take on new patients from someone else's practice.
Right.
And so when a person who's doing well on opiates with chronic pain is in a practice which, through no fault of your own, winds up being a problematic practice and gets targeted, typically for very good reasons, because of the behaviors of the practitioner, not because of the behaviors of the patients. That group of patients do wind up seriously flocking into detox units or looking for other doctors who might pick them up and generally not finding them. That is true. I think the opiate prescribing epidemic was fueled by hysteria about pain, inappropriate pressure on prescribers to look for pain and over-medicate pain with medicines that work best short-term. And I think coming down off of the epidemic of opiate prescribing is being fueled by fears about addiction and overdose. And so both swings of the pendulum, both have been fueled by concerns. One about the undertreatment, the rampant undertreatment of pain in America, which was an ill-founded concern. And the recommendation was an ill-founded recommendation of long-term opiates. And now the trying to get every doctor in America to prescribe fewer opiates when the majority of doctors don't prescribe a whole lot in the first place because of a concern of overdoses is also an unfounded strategy.
We only have a couple more minutes, and I want to make sure that I get to a question that came from the audience. Do either of the doctors who are here tonight, have you ever suffered from chronic pain?
I do now. I had chronic pain earlier in my life from some injuries in wrestling in college for several years, and now, I mean, I don't think you can make it to 62 in America without having some kind of chronic pain. Mm-hmm. Yeah.
I'm only 43. However, no, I think I'm there. I'm not quite sure, as my physician assistant probably could attest to. I had a neck injury a few years ago, and I have some chronic neck pain, untreated, because like most physicians, I'm a very bad patient. But it ebbs and flows. So.
And,
trade your bodies.
And are either of the doctors accepting new patients or giving consultations?
I certainly am accepting new patients for medical withdrawal from opioids or acute detoxification from opioids. But I'm not accepting new patients to prescribe them long-term opiates for chronic pain, except in the addiction setting of a methadone clinic or a Suboxone clinic.
I need to get your card. I am absolutely accepting new patients for chronic pain management without Schedule II opiates, and that's how I manage chronic pain.
But I think you mentioned before that if patients have been on opioid medications, you would consider taking them on if they agreed to a taper, or was that before and you're not doing that
So
anymore?
to be clear, I'm happy to assess and evaluate any patient with chronic pain, whether they're on opiates or not on opiates. What I do not do is take over prescribing those Schedule II opiates. I'm happy to work with their primary care physician to wean them off opiates. I'm happy to educate them if they have the resources and medication stores to wean themselves off opiates. I'm happy to work with an addictionologist to get them off opiates,
Mm-hmm.
and I'm happy to walk them through that and then take hold of them once the opiates have been flushed out of their system and then help them manage their chronic pain.
And this is going to be a good question for you. What can be done for new patients who have chronic pain but aren't on opiates and maybe don't want to take them?
Oh,
Yeah,
that's a
right up
layup.
your alley.
That's great.
Right.
Don't see me.
Well, it's not one size fits all, and we take each patient, we take it case by case. It depends on what the nature of the pain is, obviously. There's everything from nutritional medicine to non-opiate-based pharmaceutical medications to physical therapy and rehabilitation to psychological treatments to injection therapy to regenerative medicine to quarterbacking interactions with surgeons, and really beyond. I mean, there are a lot of things that can be done. Sometimes it's dependent on will and the underlying cause of the pain. Oftentimes, it's about figuring out what is generating the pain. Mm-hmm. Is there an anatomical locus for the pain? Is this a neurological condition? Is it both? So we take it case by case.
Well, we are a few minutes over. Thank you, everybody, for coming tonight. And thanks. That's it.
Thank you.